Cloud. Resume recording. There it is. Sorry, it took me a second. All right, so this is actually something that I used to do with any medic or advanced EMT that I had come in from out of state. Is I used to actually sit down with them and go over the protocol. It's just not the whole protocol, because obviously you guys can read, but some of the idiosyncrasies in the Pennsylvania protocol compared to the area where they may have worked in the past, simply because of the fact that we don't obviously want to do things that are outside of the confines of the protocol. So I don't think this will take super long. I think that it will give you guys an opportunity to ask questions. If anybody has any questions, just take yourself off mute and say, hey, I have a question, and we'll go from there. When you pull up the 2020 protocol, you're going to see that the only thing that changed in 2020 was some additions for COVID, just like in the BLS protocol. I used the 2020 protocol for this one because it really didn't make a difference. I just marked it up instead of the other one. The first several pages are generalized stuff. It does give you an indicator on page 4 here of the initial protocol that there is a state medication list and that there is a state list of skills and procedures that different levels are permitted to use. Those are available online. I have them. Dispatch should have them. Rachel has them. Tammy has them. So if any question comes up related to, especially on the interfacility side, if you're allowed to do a certain thing, or if you're allowed to use a certain medication or transport it, you can reference back to the state drug list and to the state scope of practice. And that, if you don't get a clear answer from that, just ask me. Somebody can call me. Rachel can give me a call or whatever, because I've probably had the question 15 times past at a minimum. All right. I'm going to go ahead and mute everybody as they're coming in, just in order to make sure we don't have background noise. So like I said, if you need anything, unmute. The other thing in here has to do with drawing blood samples. Some receiving facilities want them. For those of you in the area in Mercer County, you'll see that on any kind of chest pain or stroke, it is very common for Sharon Regional and for Farrell to want blood draws prior. So just make sure you're using their blood draw kits. In Sharon in particular, we'll actually send these to the lab. They do use them. They'll send them to the lab before the patient initial assessment is even done on a cardiac patient, just so they can get cardiac enzymes started ahead of time and get on entry troponin levels as the patient comes into the ER. So it's not like several facilities that I've been involved with in Ohio where they don't even use your bloods and they just kind of throw them out. That is not the situation that you'll run into, especially at Sharon. So just make sure you're familiar with those blood draw kits. This is what was added for the COVID-19 pandemic. You guys have heard enough about COVID, so I'm just going to jump to the next one. Protocol 1101, ALS released a BLS statewide protocol. This is an ALS protocol that applies to BLS as opposed to a BLS protocol that applies to everyone. And I've never quite figured out why, but it does tell us what to do when ALS and BLS services have both arrived at a patient incident, or if you have an ALS provider and a BLS provider on the ambulance crew together. It requires by policy and by protocol, the ALS provider to perform and document an initial assessment. What we have done in the past, and it has been pretty successful in avoiding any kind of questions or conflicts, is had any trip where a paramedic and an EMT, or an advanced and an EMT, were together that were transported by the EMT, they were not, the EMT did not completely close out and lock out the chart in the patient care reporting software and EMS charts in our case. What has to happen when that EMT is done with the trip sheet is the paramedic has to go in, review it, add their own commentary. And for these purposes, this also applies to the advanced EMTs, Ricky. Add their assessment because they were the highest level of provider on scene. And then that individual can lock out that chart. If it's 2 EMTs, obviously the other EMT doesn't need to do that, but having a policy in place that makes sure that the ALS provider actually does their assessment and documents it appropriately allows us to bill for ALS, allows us to have the extra protection in a court of law, etc. Okay. All right. Again, as you guys come in, I'm muting you unless you have something to say. Unmute yourself. Confirmation of airway placement protocol number 2032. It is not an option in Pennsylvania to do actual waveform end-tidal CO2 monitoring. Therefore, make sure you're very familiar with it. It's also a great way, as you guys should know. I'm not here to tell you how to be medics or advanced EMTs. I didn't really give you an intro, but I think most of you at this point figured out who I was last week, so that's why I didn't bother wasting the time with it. But clearly, I've been a paramedic forever and helped even in writing some of these protocols. It's a huge benefit in determining return to spontaneous circulation in cardiac arrest patients and your efficacy of CPR. So end-tidal CO2 monitoring is a huge thing in the state. It has to be done, all right? A lot of people like to go use those colorimetric devices, the theft detectors, whatever the case may be. We really strongly prefer waveform. Crashing patient in extremis. This is a protocol that was introduced probably about 3 or 4 years ago. And it's kind of an interesting protocol because it basically tells you to stop trying to load the patient and run as fast as you possibly can and actually do some things to prevent them from going into cardiac arrest. I know that may seem contrary to what some of you have learned in EMS in the past, but this is what the protocol in Pennsylvania states, and it's been very clearly proven that this is quite beneficial. It was a pilot down in the Pittsburgh area for several years before it was actually released to the entire state. I have seen great things with this. Make sure that you understand and read this protocol. Because what it's going to tell you to do is, again, a little bit contrary to what your past thinking may have been, which is actually stop and make sure that you're stabilizing before you move the patient, because we're getting better outcomes when we're doing that. It also gives you the ability to, and this is the first time you're going to see the first time you're going to see the option for micro doses of epi given instead of infusions. It's actually written into the protocol in numerous places. We're going to talk about it more in depth later. Also know that you can do pressure infusing of 500 cc's. You'll see that later as well. 500 microgram epi boluses. You'll see repeated over and over. This is better explained later in the protocol. Just know that it applies into this protocol as well as some of the others where we'll cover it a little bit more in depth. This is something that Pennsylvania introduced a few years ago when they wrote epinephrine infusions almost completely out of the protocol. And it's been pretty effective and pretty easy to implement, okay? Again, make sure you read it. We'll go through the epi thing later. That's all I wanted to point out with that one. There is also one for pediatrics, which also gives you the ability to pressure infuse that 20 cc's per kilo of saline, or 10 if the kid seems to be in cardiogenic shock. Clearly, that would be some kind of an inherited problem, as opposed to a child that is having some kind of actual cardiac injury from whatever. But just make sure, again, that you're familiar with the protocols because they're very beneficial. Airway obstruction is normal stuff. It does give you the ability in the protocol to do simultaneous laryngoscopy and abdominal thrusts. Obviously, a 2-person procedure. Read up on it if you need to. It's not written into a lot of the protocols that I've seen from outside of the state of Pennsylvania, in Ohio, for instance. But that slat technique can be very effective if you do have an airway obstruction that you really just can't get a hold of, and it may prevent having to go down the path of cricothyrotomy. Since cricothyrotomy is on this page, that's something you're going to have to work with Sharon Regional related to. We have actually not done needle crics in Mercer County for an incredibly long period of time. You can use new trach devices or you can do a straight surgical procedure, a surgical cricothyrotomy if you get to that. We used to have cricothyrotomy kits on the ambulances. Obviously, I don't know what's been changed on those units at this point, or if anybody has checked to make sure that the dates weren't expired on the scalpel.
I stocked a kit. I stocked a unit today. Unit 706 is up to date, and there is a kit on there, and
Okay.
it is dated well. We're good.
So make sure you familiarize yourselves with those kits. And when we finally get to the point where you can do a skills review at Sharon Regional Medical Center with the medical director and the EMS staff there, you'll actually be practicing those on pig throats, I have no doubt, for those of you that have done that before. General cardiac arrest. In Pennsylvania, we do not do a step-up protocol for defibrillation in adult cardiac arrest. Keep in mind that we don't have monophasic defibrillators. Your defibrillators are biphasic. And as such, I'm going to stick with this one for now, but I'm going to, oh, where'd it go? There it is. Pull up the actual ZOL data. This will become important later as well. The rectilinear waveform for ZOL, these are the equivalents. This is just a document you can pull off the internet of what the monophasic doses are versus what you should use biphasic. Since the protocol says you're going to use 360 monophasic or the biphasic equivalent for every defibrillation for an adult, that means that you're going to be doing 200 joules every single time. Now, I'll pull this up again when we get into the synchronized cardioversion locations, because it's kind of interesting that we're usually starting at 70 or 75 with the biphasic synchronized cardioversion instead of 100. And then instead of doing 200, we're doing 120. Instead of doing 300, we're doing 150. So you're kind of not really cutting it in half by 50%. So this is something you're going to have to familiarize yourselves with to make sure you remember these doses when you get into those protocols. Okay. All right, let me get back to full screen mode if I can. Where did it go? Oh, there it is. Yeah, there we go. All right. A little bit easier for you guys to see when I do the full screen mode. All right. That's really all I wanted to point out in that particular page of the general cardiac arrest protocol. We do have the option between either amiodarone or lidocaine, or if it's a polymorphic polymorphic pulseless ventricular tachycardia, in other words, torsades, 2 grams of mag certainly called for. We don't do bicarb unless it's a known hyperkalemia patient, like a dialysis patient. We don't do calcium unless it's a known hyperkalemia patient. You can give those without call-in if it is a dialysis patient that's in cardiac arrest. You will notice that Narcan or naloxone is not mentioned anywhere in the cardiac arrest protocol. It is mentioned in return of spontaneous circulation in a non-intubated patient, but we'll get to that a little bit later, okay? That's it for meds. I mean, you're going to give epi, you're going to give either amiodarone or lidocaine. It's not an and or, it's just an or. Or if it's torsades, you're going to give mag sulfate and not do the other ones. And if you actually read through the protocol, it'll explain it pretty well for you as to what you should do. If you witness a precordial thump is still permitted, this was in question a few years ago. That's the only reason I pointed out. There is a huge emphasis on correct and continuous CPR. There's a lot of science behind that. You can use impedance threshold devices if you have them. That's been intermittent as to when they have been on the trucks and when they haven't been. The data supports it. They're really expensive. No one really uses them in the area, although I'm a firm believer of them. Keep in mind that repeat doses of lidocaine are half of the initial dose. The repeat is actually written as 0.75 milligrams per kilogram every 5 to 10. So it's not give 1 to 1.5 and then give 1 to 1.5 and then give 1 to 1.5 until you get 3. It's give, and then for a while it was 1 to 1.5 and then you'd repeat it at a half to 0.75. What you're going to find with lidocaine is you give 1.5 per kilogram and then you give 0.75 and then you give 0.75 and then you're done because you hit your 3. Okay. Amiodarone is normal dosing. Field termination and resuscitation has its own separate protocol. And this is an important one. After return to spontaneous circulation, cardiac arrest is most likely to recur in the first 10 minutes. So the protocol specifically tells you to delay transport of a post-arrest patient for a full 10 minutes to make sure that you are stabilizing them, because we're getting better long-term outcomes with that kind of an approach to these patients. I know the families are a problem with it, but just suck it up and tell them that you're in charge and to shut up, and you're going to do it the way that the protocol says to do it. All right.
So they don't follow AHA ACLS.
There is a whole protocol for return of spontaneous circulation that we'll go over, but this is what the protocol is today.
Yes, Jacob, this is much different.
Yeah, that's why we're doing it.
Okay.
And
I meant prior to
make
ROSC,
a little more sense when we get into that specific protocol about ROSC, because what they found was happening a lot, and it's happening in EMS for as long as I've been in EMS, for longer than probably about 2/3 of the people at the company now have been alive. Is we get a return to spontaneous circulation in the first 5 or 10 minutes, and then we go, oh, we need to get them to the hospital before it happens again, and then they arrest on the way to the ambulance, and then we can't do adequate CPR. So instead of rushing it, let's get them stable and let's make sure they're not going to arrest again before we're packaging them, and not rush and take our time. And again, the data showing that they're getting better outcomes with it. And it's funny because it's now supported in the American Red Cross version of ACLS, because I just did that, but I don't think American Heart has caught up with it yet. So anyway, we'll talk about the protocol when we get to that one. The pediatric side, there's nothing specific or exciting to point out. It's just pediatric cardiac arrest stuff. Traumatic cardiac arrest, make sure you take a good look at that BLS DOA protocol we talked about last week, number 322. It's incredibly important, simply because of the fact that some of these patients you're just not going to work. If there's an apparent cause for cardiac arrest, or if it was, witnessed or something to that effect, then you certainly can. We want these patients to get to the hospital very quickly. If you are going to work them, you can give up to 2 liters of fluid. Let me repeat that. This is important. In adults, your cap for pre-hospital fluid without a medical command order is 2 liters. You cannot give 2 liters and 50 mLs without calling medical command. You hit 2,000 mLs, that's the extent of it, okay? There are epi concentrations and doses here that you can consider in these cardiac arrests as well. There was a period of time when, for some reason, we were not doing epinephrine in traumatic cardiac arrest, but if you're going to work them, there's no reason not to give epi. So just make sure you read through this protocol. I just wanted to point out that 2 liter cap, okay? Clearly, if the patient is rigored, or if they meet some other criteria to call them a DOA, don't work the patient. If it's witnessed by you, or if there's evidence that they had any sign of life within a few minutes prior to your arrival, then actually work them and do what you can. And then you can always terminate in the field if you have to do that. And there's a protocol for that as well. All right. Newborn neonatal. I just looked at this again. There's nothing that stands out from standard neonatal resuscitation. Nothing weird in the hypothermia protocol. Post-resuscitation, I just had a screen die on me. That was very weird, and I'm not quite sure why. All right. I'm assuming I'm still connected. Can somebody confirm that for me?
Yes, sir.
Confirm.
You are still connected.
Good. For some reason, I had a screen go out. I think I may have bumped it and disconnected it, but no big deal. All right. So post-resuscitation care. This is the statewide ALS protocol. We want you obviously to avoid hyperventilation. Consider sedation if the patient is agitated. The preference listed in the protocol is to sedate as opposed to extubate if they have been intubated. So this is that protocol that you're going to use in the 10-minute period where they're telling you to wait and stabilize before you actually transport the patient. It's okay to get them loaded. It's okay to get them ready, but just kind of slow down and take a breath before you run to the truck as fast as you can. get a 12 lead and transmit it, talk to the hospital, look at other factors, the H's and T's that may actually be contributing to the original cause of the cardiac arrest, so you don't repeat that particular problem. If they're hypotensive, resolve the hypotension with these little micro epi push doses, if you need to do that. If they have an altered level, double check their glucose. It'll take you a minute to do it. If they have a dysrhythmia, follow those protocols. If they're still unstable, talk to medical command about giving some kind of an antidysrhythmic. Let's say you shocked them twice. So you shocked them once, you gave them an epi, you shocked them a second time, and you got them out of a VTAC, or I'm sorry, a pulseless VTAC or a VFib, or potentially torsades, as frequently as you're ever going to see that. But they haven't had any dysrhythmics at that point. This is where you call medical command and say, hey, do you want me to give them 150 milligrams of amiodarone, or it would actually be 5 milligrams per kilogram over, a period of time, or I'm sorry, 1 per kilogram over a period of time. Or do you want me to give them lidocaine, or whatever the case may be? Make sure that their core temperature is okay. We may, at this point, in some places in the state, they actually do external active cooling. We haven't ever done that in Mercer County, just because of our short proximity or close proximity to the hospitals and short transport times. It never really made sense. So just transporting them probably makes more sense than doing the cooling. Again, if they're previously intubated, we'd rather sedate them, so sedation is listed in here. The epi by push dose, this is the first time where it's actually pretty well defined. So I'm gonna have to find the name of them. We were having a challenge with this when the protocol came out, because it's kind of hard to mix it. So what we realized you can do is there's a little connection where you can connect 2 syringes to one another, and you can take a 10 cc flush, push a cc out of it, and then connect it directly to an amp of epinephrine of the 1 to 10,000 epi, and push 1 cc of that epinephrine into that 10 cc syringe, agitate it a little bit, because now you'll have 1 cc of 1 to 10,000 with 9 cc's of saline. So you get the correct concentration, and then you can go ahead and administer it the way that it's listed here.
Wait, so one more time.
Yeah, I know it's
the
rough.
tube sets.
Pardon me?
On the tube sets for our normal saline, you're saying the adapters, the Y splits, we connect 1 high, 1 low.
No, I'm saying that there's no tube. There's a device now where you just connect syringe to syringe.
Okay, I know what you're talking about.
Literally
Okay.
you push a cc out of the flush, you hook it to the epi syringe, and then push a cc out of the epi syringe into your flush. And now you have the correct concentration to give these microdoses. So
Gotcha. Okay.
I first saw these devices about 3 weeks ago, and we really need to find them. And I'm sorry, I'm kind of looking for something here. I have a tickle on my throat and I need a Halls. So sorry that I had to stand up for a second, but it's better than me starting to cough. So this is a rough one to figure out, because we used to just throw a milligram of epi into a small bag and run it. They knew that we weren't really titrating, because it's very difficult to titrate by drips with a micro drip in the back of a moving ambulance. And none of us were carrying IV pumps or any kind of controlled infusion devices. So instead, these little micro doses are the equivalent of an infusion when you give them every 1 to 2 minutes or every 2 minutes. So giving 1 ml every minute, or 2 mLs every 2 minutes, or 1 ml every 2 minutes, depending on your target, actually gives the same thing as an infusion, but we're controlling it much better. So we're not over epiing people. All right. Dopamine is also an option. Last I knew, you still had dopamine in the drug boxes. There was no shortage on that yet, but there are shortages. So again, we're going to have to adjust protocol based upon med shortages. Same thing with the midazolam, diazepam, and lorazepam. We used to carry all three of them. I know a year and a half ago or 2 years ago, we were down to only carrying one of them. And then that had to switch. Like we only had Valium for a while. Then we only had Versed for a while. And we were unable to get the Ativan anymore. I don't think that's going to be able to be carried anymore anyway. So that's why there's three options everywhere sedation is mentioned in the protocol, because everybody carries different stuff. Now, this is the same protocol across the whole state. Every agency follows it. It's state mandatory. Nobody has their own individual protocol. So this is for the most rural and the most urban areas in the Commonwealth. So there are some little optional variances by region that we'll talk about as we go forward as well. Termination or resuscitation, just to make sure you read it. Technically, we can terminate after 20 to 40 minutes of ALS care. And you've had a persistent end-tidal CO2, or if you've had a persistent end-tidal CO2 of under 10 for at least 20 minutes of resuscitation. So clearly you're going to have an advanced airway in. You're going to have the end-tidal CO2, from your heart monitor actually hooked up. And you're going to have to document that you've had that at less than 10 for at least 20 minutes. I've actually had cardiac arrests in Mercer County that I've worked on scene for more than an hour with successful outcomes and discharge from the hospital. So it is possible to do it if you follow the rules. Make sure you understand this protocol well. The medical command physicians are quite used to getting phone calls where I just call them on the cell phone because I don't like to do this over the radio. So make sure you have the cell phone numbers for the command facilities for the recorded lines to get to the physicians. They should be in the unit cell phones already. I always carry it in my own cell phone and I pick it up and go, yes, I need to talk to the doc. Hey doc, this is Glenn from Elite. Here's my situation. We have, intubated. We've had an end-tidal CO2 of between 5 and 7 for the last 10 minutes. They've been asystolic for 10 minutes. There's no response to therapy. They've had 3 or 4 rounds of epinephrine. We either got an IV or an IO, et cetera. And we are requesting permission to terminate resuscitation. That's a normal thing. The challenge is the families don't understand it in a lot of cases. So you have to be very sensitive when you're actually implementing this protocol. A lot of providers default to transport because they don't want to deal with the families. I'm a personal believer in following the protocol as it's written. So I learned how to deal with the families. I just want you to be aware it's there. I'm not telling you what to do. You make those decisions based upon the protocol. Just make sure you fully understand the protocol. You will love this protocol when you have a 600-pounder in a trailer that was a cardiac arrest and you can't get them out of the house in any kind of a safe manner. All right. So any questions about that, let me know. You can only terminate resuscitation clearly after a medical command physician told you. And that's written in there so some family doctor can't call or show up on the scene and tell you to stop. Like they're not allowed to do that. You're not allowed to listen to them. And that's an important point. You are not allowed to listen to them in the Commonwealth of Pennsylvania. It has to be a medical command physician, period. That's the only option. Airway management protocol says you get 3 attempts at intubation, and then you have to go to an alternative airway like a King or an iGel. Last I knew, we were carrying Kings. I'm a huge fan of the iGels. That's up to you guys as to whatever you guys want to do.
We carry Kings. We still carry Kings.
Still carrying the King LTs, yeah, and they're pretty universally accepted by the hospitals in Mercer County. The ERs are using them as well. At first, they looked at us like we were crazy, and then they went, well, yeah, we're just going to keep these in. And we're going to start carrying them. So that means you can replace them at the hospitals if you ask as well. So you don't have to keep buying them over and over and over when you use them. Keep in mind, the protocol says an endotracheal tube attempt has occurred anytime the laryngoscope passes the lips. That's actually written into the protocol. And you are not by protocol allowed to do a cumulative 3 attempt, anything more than 3 attempts. And that's cumulative for all of the providers on scene. So if there's 3 paramedics on scene and everybody takes 1 shot, that doesn't mean you all get 3. That's it. 3 is 3, and that's the end of it. You will see written into this protocol, topical, atomized, or nebulized lidocaine and tetracaine for ALS may be used in ALS providers who are qualified to perform drug-facilitated intubations or sedation-assisted intubation protocol, blah, blah, blah. The sedation-assisted intubation protocol is not accepted. It's an optional protocol at the regional level. They do not do that. You don't use that protocol in any of EMCO West's region, which means that if you're a Lawrence County provider in Newcastle, you might use it. If you are anywhere between Erie and Sharon or Hermitage, you're not using it because that falls under EMCO West, and they've never adopted the protocol for sedation-assisted intubation. It's just an important thing to know. I don't want you guys to read that protocol and think that you can administer sedation just to assist with intubation. That's the next protocol, sedation-assisted intubation. And as I said before, ignore it. You can't do it. Don't even read it. Don't memorize it. Don't play with it. It's a cool protocol. I fought it for years. They wouldn't budge. Allergic reaction, relatively standard stuff. Asthma, COPD, obviously CPAP, BiPAP for both adults and peds. Last I knew, you had 3 different sizes of CPAP masks, including a pediatric size, and then a small and a large for adults. Use them on the kids. They work great. Croup and Stryder, the only place in the protocol where you can actually nebulize epinephrine or give the 2.25% racemic via nebulizer. We started to carry racemic a couple of years ago, so it should be in the drug box. You should have 1 or 2 doses of it available in there. Volume controlled transport ventilator management is a statewide ALS protocol related to transport vents. Elite currently, as of today, unless Rachel bought one in the last 3 weeks, does not have a working transport ventilator, so it will not be an issue for you for now.
Interestingly enough, Glenn, Katie informed us that, and I am trying not to laugh, medics are not permitted to transport vents in the state of Pennsylvania anymore. That's what Katie told us. So no, we do not have a ventilator, but I do have access to a ventilator, and that's something we can investigate in the coming months.
Yeah, investigate is a good word for it. Make sure you read through the protocol.
Actually, when we were doing inventory at Elite, we do have a vent there, but it's not working. Right.
No, it's non-functional. No.
Hold on. There's 2 of them. I'm the one that bought them. They worked fine. We didn't use them for 2 years. We went to check them one day. Neither one of them was functioning, and we made the decision not to pay the cost to continue to maintain them since we had not had a request to transport by vent for 2 years. So we just dropped the vent thing because, in all honesty, if somebody calls for a vent, it's so infrequent that we were having more problems with maintaining the skill level on the ventilators than it was worth to pick up 1 trip every 2 years. So that's a decision that is out of my hands now. I'm quite familiar with those ventilators. You actually could send, they're great vents. I bought them at an auction. You could send them for Biomed, and they could be, I'm sure, quite functional. So I don't know what it would cost you, but that's up to you. If you ever do get into it, though, boy, you better understand this protocol, because the medical director has to approve any transport ventilator. They have to assure ongoing competence. You have to have the capability of doing, again, waveform capnometry, et cetera. And you have to do it while ventilating. Like, there's a lot of protocols and policies related to these vents that are a real pain in the butt. Okay. All right. Suspected acute coronary syndrome. You have Sharon Regional is going to be your cardiac center. UPMC Horizon may tell you that they can take cardiac patients. Theoretically, you can transport them if that's where the patient insists on going. But Sharon Regional not only has PCI capability where they can do rescue angioplasty, but they have an open heart program as well. They're the only ones in the county. The next closest is St. Elizabeth's over in Youngstown. Jameson is supposed to be doing it, but last I knew, they still weren't able to do rescue angioplasty 24/7 the way Sharon Regional is. So in order to facilitate this, though, they want early notification, which makes a lot of sense. And that means that they expect you to adhere to the American Heart Association standards related to when you're getting 12 leads. From the time you walk in the door to the time the 12 lead is obtained should be less than 5 minutes and documented as such. You always have to document if you considered or administered aspirin and nitro. And it's basically a 5-minute rule for everything. 5 minutes to get it, 5 minutes to transmit it, 5 more minutes, you better be talking to that physician. Don't waste time on these scenes. Get the 12 lead early, get them loaded early, get the notifications done, get them to the hospital. You can do those notifications through the triage program for Sharon Regional as well. We did have it on the phones in the units at one point. And Rachel, you can work with.
Also, you guys, Triage is going to be hosting a Zoom conference March 4th. You'll see it on the schedule. You'll be provided with your own Triage accounts. That did fall to the wayside. It's being remediated. So within the next week, you'll hear more about Triage, just so everybody knows.
Yeah, I was just about to say the same thing. As you guys, it's really easy to get it arranged. So you guys all have your own accounts. I still have an account on my cell phone for Elite, just in case I show back up, because I actually do have command for 2021, even though I'm 6 hours away. So at least I'm assuming they gave me command when I turned it in. Anyway, that's all I wanted to point out. Just that 5-minute rule, though. Expect if you don't document it appropriately, they will come ask questions about why it took you too long, or why you didn't document when you got the 12 lead, why you didn't document when you gave aspirin, if you considered aspirin, if they had an aspirin allergy and that's why you didn't do it. People are going to ask questions, so make sure you're following this to a T as best you possibly can. It does have written in not to give nitro, again, if they've taken any kind of, erectile dysfunction med, and to use, and this is important, just make sure you're familiar with the process. Be real careful giving nitro to patients that have inferior wall MIs. At least if you don't consistently do it, consider doing right-sided 12 leads on those patients, because I've had a couple of medics in the past that didn't really understand this, and they just, oh, well, okay, they have an MI, I'm going to go ahead and give them nitro. But in those inferior wall MIs, if it's actually a right ventricular MI, you're going to tank their blood pressure like really badly. So be super careful about that. A right-sided 12 lead takes an extra 2 minutes. It's worth it. And I will transmit those and write right-sided on them if I have to, as well. All right. This is the reason that I started doing these protocol reviews, and it was all because of the congestive heart failure protocol. About 8 or 10 years ago, we decided to do something bizarre, and give really weird dosing of nitroglycerin in congestive heart failure, but it works really well. So in a patient with a good blood pressure, if they're not taking Viagra type drugs, they get 1 to 3 doses of nitro every 3 to 5 minutes. Let me rephrase this. Let me say it one more time for emphasis. Your initial dose will be 1 dose of 0.4 milligrams, either by tablet or spray. And then your second and subsequent doses are based upon systolic blood pressure. So if they have a systolic over 180, their second dose is 3 nitros. If they have a systolic between 140 and 180, it's 2 nitros. And if it's between 100 and 140, it's only 1 nitro. Now, this isn't just for a chest pain patient, it's for a CHF patient. So you're also doing a CPAP, which means it's really hard to give nitro. So that's why we also have the ability to do nitro paste, 1 to 2 inches of topical. And what I have typically told people to do is, if they have a lower range blood pressure, somewhere in the ballpark of 160 or below, give 1 inch. If they're 160 or above, give 2 inches. That way you can have that continuous nitroglycerin going through, the transdermal route while you're doing CPAP, and you don't have to interrupt the process. I've never seen a protocol anywhere else in the country, and I've only been in 46 states now. Okay, I've never seen an EMS or a congestive heart failure protocol like this anywhere else in the United States. So it's a really interesting twist, and that's why we actually started to do this. It does say there's an option for a 200 mic slow IV infusion of nitroglycerin. You are not going to be doing that. We don't carry it. Nobody wants that to happen. The nitro paste for transdermal is more than good enough for those patients where you don't want to keep cracking that CPAP seal to give them sublingual nitros, if that makes sense to everybody. And yes, you have to memorize these levels of 180, 140 to 180, or 100 to 140. But if you forget to memorize it, go to the UPMC EMS app you can download on your smartphone and look it up on the way to the damn call. Or pull it up on your phone and look at it after the first dose, so you know what to give for the second dose, depending on what their systolic is. Nothing exciting in bradycardia, except again, epinephrine by push dose is described yet again. Prepare 10 mics per ml by adding 1 cc of that 1 to 10,000 concentration into 9 cc's of saline, and then give 1 to 2 cc's every 2 minutes and titrate to systolic. It's a really cool way to do it. I'm completely behind it. We used to do the set it and forget it with dopamine in these patients. Just turn it on until they had a response and then back it down, because there was no way to count 5 or 10 or 20, or 15 mics per kilo per minute. But the epi's much easier to control in the back of a moving vehicle. All right, narrow complex tachycardia. I need to ask, did you guys ever get Cardizem back?
Does anybody know the answer to that question? Because I have had nothing to do with drug boxes.
I hope Jacob does.
For Trumbull, we did not get Cardizem back. UH is still actually in the process of debating whether they want to take it back.
No. I'm asking about at Elite in the drug box. Is there Cardizem?
At Elite, negative.
There's no card. Okay. So the problem became storage and accessibility with Cardizem. Don't be surprised if you get it back at some point. And then we just kept it in a little separate like baggie and replaced it out like every 30 days or 60 days out of the refrigerator. There was a stable form of it. And the problem was that after the hurricanes in Puerto Rico, they couldn't get the stable forms of it anymore. So they gave us Verapamil instead. So this is where that Verapamil plays in.
We still have Verapamil.
Yeah, that's where the Verapamil plays in. So hopefully you'll get Cardizem back at some point. It's a much better med. I'm a huge firm believer of it. Part of the problem in EMS is there used to be a Lyaject form that you could reconstitute, and it came off the market. Meridian stopped making it. So, it is what it is. This is also where the synchronized cardioversion between, again, 50 and 100, and then it says repeated 100, 200, 300, 360. That goes back to that same document that I already showed you with from Zoll that had different levels for synchronized cardioversion of 70 to 75 for your initial instead of 100, 120 instead of 200, 150 instead of 300. I would almost take a look at this and laminate it and attach it to the monitors if you guys want to have a ready reference for it. Okay.
It's attached.
It is good.
There's a card guide in the back. If you guys are missing it out of your monitor for any reason, let me know.
Now, it's the protocol will say that these levels have to be approved by the medical director. They were approved by like 3 medical directors ago. They keep switching medical directors on us. So I don't think that Dave Schellenberger have any question about the fact that we're just following the Zoll guidelines. So the other interesting thing about the tachycardia protocols for those that are not unstable. I mean, obviously an unstable tachycardia is narrow or wide. We're going to go ahead and do, sedation and synchronized cardioversion, which we just talked about. But if you look at ACLS protocol, it usually has stable or unstable. In the Pennsylvania protocol, we have stable, unstable, and then the gray area in the middle, which is called borderline. and there's a different set of rules for them. But you guys have seen these borderline patients, like they're on the low end of blood pressure, but they're not really in shock. They're short of breath, but they're not really in florid pulmonary edema. Their chest is tight, but it's not chest pain. They're in the middle, okay? Their Glasgow's good. They're alert and oriented. So they're not stable, but they're not bad. They're in the borderline range. And what the protocol has done is given you the ability to use your assessment skills to make that judgment and say, I can try some meds, and if they don't work or if they get worse, I'll go ahead and go down the unstable path and do synchronized cardioversion. You will see these exact descriptions, and it makes perfect sense. They're taking a conservative approach because synchronized cardioversion is not a benign process. You're attempting to use electricity to cease cardiac activity for a short period of time. Some people forget to sync, therefore you can actually put people into cardiac arrest. It's not benign. So in those gray area patients where they're not great, but they're not horrible, try meds first. That's all this is giving you the ability to do, if that makes sense, okay? Unless they're multifocal atrial tachycardia, and then don't give them medications ever, because we just have to shock that. So, and that's also in the protocol. We've talked about pretty much everything I want to talk about in this one. You'll see the same things on mine, you'll see the same things highlighted in the wide complex tachycardia as well. Pediatric, there's really nothing huge to point out. Wide complex tachycardia, same thing, although it does add torsades if it's polymorphic, or I'm sorry, magnesium if it's polymorphic or torsades. It has the same thing related to synchronized cardioversion, same thing related to borderline versus unstable. So just make sure you're familiar with those different levels, okay? And pediatric wide complex, nothing exciting there. Multi-system trauma. Avoid overzealous hyperventilation. My opinion is you should be using your capnometry, your end tidal waveform capnometer on all of these patients, or capnography as the case may be. Not capnometer, it's capnographer. And making sure that you're maintaining their CO2 in that 35 to 40, no more than 45 range. Just so you're not blowing off all their CO2 and getting their CO2 down to like 20. That can have some negative impact, obviously, on the cerebral side of the house. So try not to do that. 2 liter max on fluid infusions, as we said before. With pediatrics, your fluid max is 40 cc's per kilogram before you call medical command. So you get 2 trials at 20 cc's, and that's it. If it's a sucking chest wound, the protocol says to cover with an occlusive dressing sealed on 3 sides. This did not solve the 3-sided versus 4-sided occlusive dressing question that has been coming up in EMS for years. We have been carrying commercial occlusive dressings that are actually just adhesive pads that go over the thoracic wall opening, or they work on necks and abdomens as well. Those are completely acceptable in addition to this 3-sided thing. So if you're making one yourself, tape on 3 sides. If you're using a commercial dressing, nobody's ever complained about them. We've used them for years. Pain management used to be different than it is now. We used to give fentanyl to people with isolated extremity injuries like it was candy. They backed off on that, and instead of doing nasal fentanyl for every old woman with a hip fracture, without calling medical command, we now give them Tylenol or ibuprofen. So make sure you're carrying it. Make sure you have your Advil and your Tylenol on the truck, or whatever the case may be. Now, in addition to that, you can contact medical command when appropriate for analgesic medication. The doses are relatively normal here. I am, however, like the max of morphine is 10 milligrams. The max of fentanyl is 300 mics. You're going to see very different max doses when you get into the burn protocol. It's the only one where it's really excessive. It does say ketamine is an option. Ketamine is only an option if you have gone through a very extensive ketamine program as both a service with your medical director and the state, and specific training for all the individuals. We are not at the point where you guys are ready to take on the ketamine process at this point, but hopefully within a reasonable period of time, when we get some stable Pennsylvania certified medics that can actually do the training, we'll actually move down the ketamine path as well. It's okay for the musculoskeletal. It's great for the agitated patients that we'll talk about here in a little bit.
See, and that blows my mind that they wanted over 10-minute time frame through 100 mLs. Here in Ohio, we do 10 milligram, not bolus. We do 10 milligram boluses max, but we have to dilute it ourselves.
Well, you got to figure in a standard adult, let's say they're 70 kilograms, supposedly. I think it's closer to 100 personally. You're given 20 milligrams over 10 minutes. That's pretty effective for pain. I mean, that's more
Right.
along the lines of what the military was using. But we're also able to give up to 300 mics of fentanyl, which is also incredibly effective. So,
Right. I'm not saying it's not. It blows my mind that they don't want it in the bolus. Instead, they want it infused.
in the musculoskeletal trauma, it's an infusion. In the agitated patient, it's not.
It's a bolus. Right.
Yeah, well, yeah, because there's no way you're going to start a line and have them lay still for 10 minutes while you infuse anything.
Right.
Yeah, you're going to stick it in their eye for all I care. No, don't do that. I'm kidding. Anyway, all right, crush syndrome, pretty standard. Blast explosive injury, pretty standard. Burns, max dose of morphine is 10 milligrams per dose, repeated every 5 minutes. You got to love this. Up to a max of 0.2 milligrams per kilogram. So again, in a 220-pound adult that weighs 100 kilograms, your max goes up to 20 milligrams. But if you get a bigger patient, you need a second truck because you don't carry that much damn morphine. So you theoretically can give up to 30 milligrams or 40 milligrams of morphine in these burn patients, depending on their size. Same thing with fentanyl. You only carry 300 mics. This is why you carry 300 mics, because 2 ambulances together on a significant burn patient, you think about that same 220 pounder, 3 mics per kilogram. Okay, that's your 300 mics. But if you look at your bigger patients that weigh 150 or 200 kilos, you can double that. Like, it's a lot of fentanyl, but burns hurt. So they have given you the ability to do this and step it up and watch the respiratory status while you're going. It's worth pointing out because it's an exception to the normal rule of how much we give. Hypothermia, no big deal. Heat emergencies, no big deal. Altered level of consciousness with a glucose of less than 60 is 10% dextrose. For those of you that are accustomed to D50 or D25, Pennsylvania has moved to D10 and some more D10. You may still have D50 floating around, but theoretically, D10 is the answer to the magic question. This also tells you how you can give Narcan, obviously, basically any way you want to. 2 to 4 milligrams intranasally, 2 milligrams IM. It tells you to split it between nostrils, all that kind of good stuff. And it also is very clear that the goal of giving Narcan is to have a return of adequate spontaneous respirations. I consider Narcan to be a respiratory medication, not a neurological medication. If they're breathing adequately, let them be stoned. Don't be mean. They paid for it. Let them keep it. Okay? As long as they're breathing okay. Under no circumstances should you be giving Narcan to a patient that is breathing on their own adequately with good respiratory exchange and a decent pulse ox. Let them be snowed. It's better than them kicking your ass in the truck.
Don't piss them off. Don't piss them off. Just,
well, and they're really,
I mean,
we don't want to precipitate the physiological impact of throwing somebody into a withdrawal syndrome. So stop giving Narcan just because they said they took heroin and only use it as a respiratory med. Anyway, off my soapbox. Altered level of consciousness for peds, same basic thing, no big deal. Non-traumatic pain management. Oh no, my belly hurts. They can get Tylenol or ibuprofen if it doesn't look like they're bleeding. Read the whole protocol. It's pretty much the same as the musculoskeletal pain.
Now, we don't carry nitrous oxide. I keep seeing nitrous oxide pop up.
No,
for pain,
we don't carry
but
it.
We don't carry it.
And we don't carry it for a reason, because EMS people are untrustworthy and they would be stoned up on nitrous oxide all the time. Well, it's true. I come from the military side of the house, and we had nitrous tanks in military medicine, and I never saw one that wasn't empty. I can't figure out why. All the oxygen tanks were full. I would lie if I said I never put on a nitrous mask myself, but we're not going to go down that path. This is being recorded. Okay. Yeah, we don't do it. It's legal, but we don't do it. Shock and sepsis, 500 cc's rapid infusion. This is important. It's for sepsis, 500 cc's rapid infusion. For sepsis, I know you guys think that I'm on repeat now. 500 cc's rapid infusion. Start the IV, run the 500 cc's wide open, reassess the blood pressure. It is a huge benefit in sepsis, to the point that just like we call cardiac and stroke in the field, we were calling code sepsis for a long time. So you'll see all sorts of policies at the hospitals about calling code sepsis, letting the docs know that you have one. All right. So read the protocol. It's an important one. We get a lot of sepsis patients. Oh, look, epinephrine microdoses show up again. It's like all over the protocol. So make sure you understand how to do it. Stroke, pretty self-explanatory. There is no stroke center in Mercer County. I'm going to repeat that again. There's no stroke center in Mercer County. You can pull up the list online of where the stroke centers are. Here it is. I would like to point out, in Mercer County, there is not a single stroke center. I have one here. Actually, I have 1, 2, 3, 4, 5, 6 of them here in Montgomery County, and you have 0 of them in Mercer County. That's an important thing to know, but your best bet is still probably Sharon Regional. Your true best bet is to talk to Sharon Regional by medical command and make sure they can handle the patient. And if not, take them over to St. E's, who I believe is a stroke center most of the time, but not necessarily on weekends or busy Tuesdays. So, all right. Seriously ill appearing patient may be one of the strangest protocols you've ever seen, but you know how you get that patient who just looks like they should be ALS, like, I don't know what's wrong with them, but they look really sick. So I should put them on a monitor, and I should throw an IV in them and maybe check their blood glucose and maybe even put them on a nasal cannula. But I can't tell you why, but they called for an ambulance, so they must be sick. So I may as well do it. And we used to do this all the time, but we didn't have a protocol to justify it. Well, now we do. It's called seriously ill appearing patient. If you appear to be seriously ill and you don't fit any other protocol, I can start an IV on you. I can throw you on a heart monitor. I can do what I want. That's it. That's the only reason that protocol exists, is for your legal protection. Nausea, vomiting, you can consider giving Zofran. If they have persistent nausea or vomiting, I'm a bigger fan of giving it for persistent vomiting, not necessarily just nausea. If you give it, do it slow IV. And I'm going to repeat this again, slowly, for those of you that aren't super familiar with it. If you haven't used it before, it can precipitate migraines in a small percentage of the population. If they start to develop a rapid migraine, stop giving it, because I'd rather have them puking than have them puking with a migraine.
It can also affect cardiac rhythms.
Yes, absolutely. It can do all sorts of weird shit. So don't do that. Postpartum hemorrhage, no big deal. Agitated behavior, psychiatric disorders, basically tells you what the guidelines are for restraining patients. It tells you that you can call medical command for sedation options. This is not including the ketamine. That's a different protocol. So you can, at any time that you have a patient that is out of control, get cops on the scene to help you. Call the doc on your phone and say, hey, doc, I need to give this guy something so I can transport him. And they will probably say, what do you have? My typical answer was, I have Valium, Versed, Ativan, morphine, and fentanyl. and I'll give him all 5 if you let me. And then they'll say, no, don't do that. Give them whatever, okay? But only list meds that you actually are carrying based upon what was available. Again, the benzos we've had problems with. Ativan, I don't think you'll carry again for 10 years because of availability. The Versed and the Valium, I think you probably have Valium and that's it. I could be wrong. You might have Versed. You might only have Versed and not Valium this week. I don't know. Just give them the options that you have.
The NARC boxes have lorazepam and midazolam, both.
Okay. So Valium's the problem now. That's interesting. All right. So patients that require physical restraint, this tells you what you're allowed to do. You can put a spit hood over their over their face. We were carrying spit hoods. You can put them in soft. You technically cannot transport them with handcuffs without a law enforcement officer accompanying that patient in the ambulance. The cops are aware of that. It also says that it is preferable that a law enforcement officer follow the ambulance in a patrol car to the receiving facility if any physical restraint is necessary. That's also important. They know that. So I've had many a cop ride in the back of the truck with me because the patient was handcuffed, or told them you either have to remove the handcuffs and we'll put them in soft restraints, or you need to get in the back of the truck with me because the protocol says I'm not allowed to transport them that way. So that may be different than where you're from. Make sure you read that protocol. Excited delirium is the optional protocol where we're using ketamine for the really, horribly excited, violent psych patient that we just can't get under control. It is an incredibly complex protocol. It is a bolus, Jake, of 4 milligrams per kilogram IM in a single dose.
That's a lot.
I believe that's the.
I like it. Yeah, It says 4. That's a lot, and I like it.
Oh yeah, dude. We smack them. We actually use this protocol where I run, although I haven't run since like May of 2020 because of the damn pandemic. It's an interesting protocol. So you can read it if you want, but you're not allowed to use it. Maybe someday. Poisoning, typical stuff. If again, medical command can tell you to give whatever they want. Sodium bicarb for tricyclic overdoses. We're seeing more tricyclics now. Calcium for calcium channel blocker overdoses, or even beta blocker overdoses. Benadryl for dystonias. So just read through the protocol, but it's exactly what you would expect. Just make sure you know what's above and below the command line. Oh, and I forgot to highlight it, but this activated charcoal thing, we don't carry it anymore because it's nasty. So forget that. There is a protocol for cyanide exposure in case we ever carry cyanide kits. There is one for nerve agent and pesticide exposure in case we ever carry those particular items. Also gives you a whole lot more atropine capability if you were able to carry that much on the truck, which you don't have. But that protocol exists for those urban areas that have been given the actual, either the old Mark I kits or the newer duodotes. So they could actually carry them on the ambulance and administer them if needed. Standard medical command protocol, just, contact whenever, and that's the end of the paramedic protocol. So
we do carry atropine, but it's mainly just cardiac, and we only carry like 6 milligrams total.
Oh yeah, no,
12,
I'm talking
12
about
milligram total.
No, I'm talking about the actual like atropine.
The kit.
Yeah, the kit or the
Gotcha.
The duodote isn't even a kit. It's just a like an EpiPen, but it's a mixture of atropine and pralidoxime or 2-PAM chloride. So it's 2 milligrams of atropine and 600 of 2-PAM, and you just give it intramuscularly. So in order to do that, though, there had to be a protocol. So in Pittsburgh and in Philly and some of the other areas where they're actually carrying those, they needed to have a protocol to support them.
And then the only other one that I saw on there that I don't recall being in the ALS box is calcium chloride, but we do carry the glucagon.
Oh, no, glucagon is in the, you don't have calcium chloride?
I'm not 100% sure.
You should have one of them. It should be in a yellow preload, probably down in the bottom of the box because nobody's touched it in like 4 years. since the last time we had a dialysis patient that actually arrested.
Well, I know we have sodium bicarb. I just don't know if we had the calcium chloride.
Yeah, you should. It was in
Okay.
there last I looked.
Okay.
Unless they're out of it for some reason. All right, so the advanced protocol I wanted to go over real quick. There's not a whole lot to it. It's not a super long protocol. And I'm here to tell you I've done a page-by-page comparison of the advanced protocol to the paramedic protocol, because advanced EMTs, they're not new at Elite. We've had them before. Advanced EMTs in Pennsylvania are unfortunately incredibly different from how they are in the state of Ohio. Ohio is much more liberal with them. I think it's a pain in the ass, and I think it's a waste of education. Let me rephrase. It's a waste of educated providers, the way that we utilize advanced EMTs in the Commonwealth of PA. They have much more capability than what the protocol allows them to do. But when you compare the advanced to the paramedic on a protocol by protocol basis, it's still basically in Mercer County has been the conclusion of the services that if a paramedic is available for anything except a simple shortness of breath call, then that paramedic also must be called to assist the advanced EMT. That's just the way it is. I think that'll change as the years go by, and I'll kind of point out to you what those differences are. I didn't go through this and highlight anything because I had just downloaded the new one, but I know it well enough to just kind of go through it off the top of my head. General protocol principles, that's just standard stuff. Yes, you're able to get these were updates last year. You're able to transmit 12 leads, but that doesn't mean you're allowed to read it, and you're not allowed to put them on a continuous EKG monitor to watch their rhythm. That's not the way it works. You're only allowed to use saline. You're not allowed to use ringers. I think maybe you're allowed to use D5W as well on the interfacility side. I'd have to double check that off the top of my head. I know you're not allowed to touch ringers. You're talking about something that's asinine to me is the fact that advanced EMTs can't transport ringers. The restrictions are more significant than what you're actually allowed to do. You are allowed to start IVs. You are allowed to start IOs. Other than that, there's not a whole lot. There are indications in this protocol, just like there are in the EMT protocol, for when you have to call for paramedic backup. Notice it is virtually everything that there is a protocol for. I don't know what else to say. Like every respiratory distress or respiratory arrest, you have to call for a paramedic. Entrapment with injuries, any stroke, any chest pain, any severe pain anywhere, any cardiac symptoms, any altered level of consciousness, except hypoglycemia or an opioid that you can manage. Like there's not a whole lot of things that an intermediate or an advanced, I should say, can do in Pennsylvania. It's just not there, which is a shame. It's not the way it should be. So understand that as paramedics, what the limitations of the advanced are, and as advanced, understand your limitations as well. I know you guys went to school for a reason, to learn how to do more than what the state allows you to do. This has been an argument I've had with them for years, and they just haven't budged a whole lot on it. So confirmation of airway placement, again, end-tidal CO2 is outside of the scope of, it's within the scope of practice for the intermediate, so you're allowed to do that. That's a start. You are allowed to do IV access. It does give you a protocol to give epinephrine, to put in a King airway, and to have the AED function on the monitors perform your analysis and your shocks. What the hell am I? I don't know why I'm having a brain fart. Defibrillation. That's it. Yeah. Anyway, yeah, I had a little mini stroke. Shit happens. But other than that, I mean, so cardiac arrest, I've thought, boy, this is a pretty easy one to have you guys run right up to the point where you can't give anything but the damn epinephrine. Obviously epi doses are different for anaphylaxis than they are for cardiac arrest. Why they had to tell you that is beyond me. Make sure you're doing continuous waveform end tidal if you do the King Airways, which again, you're allowed to do. Pediatric, not much different from what you would expect in a pediatric, not much different than the adult. Traumatic, very similar to the medic. Rapid transport's a priority. You can give an IV. You cap at 2 liters of saline. Not much difference there. You can give the epinephrine in a traumatic cardiac arrest as well. Hypothermia, not a whole lot different than the paramedic protocol, other than the cardiac monitoring issue, which is why if it's a hypothermia caused by cardiac arrest, well, cardiac arrest, you can have the AED do it. I'm sorry. That's not just a hypothermia protocol. Airway management, again, allows you to do the extraglottic alternative airways, such as, again, an iGel or a King or a combi tube. So make sure you're familiar with those. It's just a protocol allowing you to do it. Allergic reaction, again, we have epi auto injectors for both adults and pediatrics, or you can actually use the epinephrine. And you can also give diphenhydramine in this protocol, but since you can't monitor cardiac, you still have to call for a medic. It was on that list of things you had to call a medic for. And that's what frustrates me so much, is in a suburban environment where the services are so close to each other. This makes a lot of sense in a rural area. It doesn't do us any good in the environment where you guys function, where, you know, an advanced could actually be a little bit more of a mini medic, and we wouldn't have to need so many paramedics if we were a little bit further out in the sticks and medics were fewer and further between. The asthma COPD, this one is the only one that is almost exactly the same for the intermediate EMT or the advanced EMT in Pennsylvania versus the paramedic. It's literally almost letter for letter, word for word, the same protocol. The only difference is the ALS protocol. It's kind of interesting because the paramedic protocol, you would think, said to put them on a cardiac monitor. It doesn't even say to do that unless it's needed. Okay. And there's differences related to the routes by which you can give epinephrine. But other than that, it's pretty easy. IM can only be given from physician order in this one. Croup and Strider, it does allow you to do the racemic epinephrine. But again, it's a shortness of breath. You still got to call a paramedic. That's the way the protocol says. Acute coronary syndrome, clearly need a paramedic. You can do the 12 lead, you can transmit, you cannot read it, you cannot hook them up to a monitor for continuous. Well, you can hook them up, but if you're independent of a paramedic, you can't just monitor their cardiac monitor by yourself, even though you guys were trained to do it. I don't understand why you're not allowed, but you're not. Multi-system trauma, same thing. You're capped at 2 liters of fluid. Same as the ALS protocol.
I've got a question about that.
Yep.
About acute coronary syndrome. So if, let's say Ricky's on the truck, he calls for a medic from McGonagall's or anywhere else, and they show up on scene, is Ricky able to read it then to tell them what he's seeing?
Nope, no? It's outside of the scope of practice.
Okay.
The scope of practice document, which is a separate document from the state, says that it literally lists like in a big grid, and one of the lines is cardiac monitoring, and then it has first responder, EMT, advanced EMT, paramedic, and then like a healthcare, like the nurse, PHRNs, and healthcare physicians, etc. in the EMS system. And cardiac monitoring is no, no, and no up until you hit paramedic.
Gotcha.
So nope, not allowed to do it. Good question though.
It seems like if that were the case, like we would be able to use him as a vital tool at that point. But
yeah, wouldn't it be cool? Wouldn't it be cool if we were actually able to use advanced EMTs for what advanced EMTs were trained to do? So here's the interesting thing from a historical perspective. There were never intermediate EMTs in the Commonwealth of Pennsylvania. So when I went to school, and I graduated from Youngstown State, with my paramedic and my associates and my bachelor's. It's all from YSU. I became an intermediate. I functioned as an intermediate for a year, well, 8 months before I was a medic. And intermediates were basically what we now use advanced EMTs for in the state of Pennsylvania. There were EMTs who knew more that were allowed to start IVs, and that was it. And then Ohio, now Pennsylvania never had them. Ohio took a turn and phased them out for a while and then brought them back under the new curriculum, and actually allowed them to do what intermediates are supposed to do, or what advanced EMTs are supposed to do. I don't remember what Ohio calls them now. Pennsylvania decided, as most of the country was phasing out the intermediate level, to add
They
it
call
in.
them advances.
Pardon me? They call them advanced? So
Yeah.
what Pennsylvania decided to do is, everybody else in the country was phasing them out, including Ohio. Pennsylvania said, let's bring in these mini medics. And that was the idea, is in these rural areas, they could be the answer to the fact that they couldn't get ALS providers because the education took too long. And then they didn't allow them to do shit in an environment where they actually had paramedics around them. So if you worked in State College and the nearest paramedic was 40 miles away, or somewhere out in the mountains in Fulton County, an intermediate is God, like related to the EMS world, because hell, they have somebody that can actually transmit a 12 lead and start an IV. That's huge. You can give nitroglycerin. You're my hero. But here it just doesn't make sense. So the protocol just doesn't allow them to do anything of any real value, despite the education and the ability. And it bothers me, as you can tell. Anyway, so this doesn't take all night. Multi-system trauma, like I said, 2 large bore IVs or IOs, and saline bolus is not to exceed 2 liters. Everything else is pretty much the same, until you get into the things like needle decompression and advanced airways and monitoring the cardiac rhythm, et cetera. And that's why you need the paramedics. Musculoskeletal trauma, the only analgesic medication option is a non-option because we don't carry it. Below the command line, that's nitrous. But you can give aspirin, acetaminophen, or ibuprofen in mild to moderate pain. Oh, you have a little headache? Here, take 2 Advil and shut up. And yes, you're only allowed to give them 2. That's the protocol that goes along with it. Crush syndrome, nothing exciting in there. Burns, contact medical command to give nitrous oxide if you had it, or if you need to give more fluids. But transport is kind of the answer. You're going to have to call a medic on these anyway in the area. Altered level of consciousness. It does allow you to give Narcan intranasally only. Isn't that interesting? You're allowed to start IVs, but you're not allowed to give Narcan IV. Oh, no, you are. That was an old one. 4 milligram intranasal. Or you can do, that was an old protocol. You're allowed to do the 2 milligrams intranasally, or IM or IV or IO. So they did fix that. And yes, you're allowed to do 10% dextrose for people with glucometers less than 60. But all the other things that go along with altered level of consciousness require you to call a medic anyway. You can see the theme. Pediatric, not much different. Same general thing. Same thing with non-traumatic pain management as we had with the isolated injuries. Shock and sepsis, 500 cc rapid infusion, just like in the ALS protocol or the medic protocol. If no CHF, you can repeat it after you call medical command. 500 your max until you call command. Stroke, pretty much the same, other than the cardiac monitoring. The protocol still says you got to call a medic for it if you have one. Stroke centers we already talked about. Nausea and vomiting, yes, you can consider giving the Zofran under the same set of rules that the paramedic had, but as Jacob had brought up, this is the reason you need to call a medic. Zofran can cause cardiac problems. Therefore, cardiac monitoring is actually preferred when you're given Zofran. So although you're allowed to give it, typically you're going to be using it. You have to call a medic in our area anyway. So that's just the way it is. Postpartum hemorrhage, no different than medic. You're going to call for them regardless. And there's your medical command protocol. So again, the protocol, I'm sorry, I hate to say it, it's just a waste of time. It's useless. It doesn't allow you to do what you should be able to do. And yet there has been no big change in years on this. So with all that in mind, and knowing that we're still recording our little message here, at least, yep, it's still recording. I had to double check. Does anybody have any questions?
The full occlusive dressing for sucking chest has a one-way valve built into them. I think that's why it's able to be used.
You broke up a little bit. It has what?
A one-way valve on the outside of it.
Oh yeah, when you're looking at like the high fin dressings or most of these commercials, they still have a way for the air to escape. That's how they're designed. So, and that we ran that by the medical director, Dr. Mayenza, and the current medical director worked in Sharon's ER with Dr. Mayenza. So when Mayenza left, Dave became the medical director, but there's been no need to change anything that that Mayenza had approved. Schellenberger is cool with, up to to my knowledge. So and I'm a huge believer in commercially available dressings like that. I mean, I think that they're just much quicker, much easier. You get a gunshot wound or a stabbing or something like that, or a neck injury, it's much quicker to slap one on than to try and make one.
Yeah. Okay. I wanted to make sure people were aware of that one-way valve system that's on it.
Oh yeah, they're fantastic. I carry them in my car along with like a half dozen tourniquets, but that's just because I did tactical stuff for years.
So you're just always expecting an MTI?
Well, no, I mean, if I shoot anybody, I want to be able to save them.
There you go. There you go.
I do live near Philly. I mean, come on.
Right.
We have riots and shit for fun. All right. I think you guys, after going through this, understand why I wanted to do it. There are just some weird little hidden gems of strangeness within this protocol, especially the paramedic protocol. If you guys ever have any questions, please do not hesitate to reach out. Rachel knows how to get a hold of me. And also feel free to ask some of the Pennsylvania experienced Mercer County paramedics that are working for the service as well. If there's any questions, I guarantee you Michelle Jewett knows this protocol as well as I do. So, I'm not by any means the end all be all that knows all the little twists and turns of it. I've just been looking at it for, the 18 or 20 years we've had a state protocol. Anybody have any questions? Rachel, do you have anything for them?
Yes and no. Like I said, we're going to be having the Zoom for triage. Your accounts are in the middle of being set up. And also we're going to be having a staff meeting, and the mock cardiac arrest will be rescheduled for the second week in March.
All right. I'll send you the recording tomorrow. I'm going to stop recording now.